Okay, hello everybody, and welcome to this month's IMV Imaging Journal Club. My name's Sam. I'm one of the clinical managers here at IMV. So hopefully you've joined us for IMV Imaging Journal Club episodes before, but if you haven't, just a quick review on how things work. So each month, a member of the IMV clinical team will choose a paper or a topic, usually a recent journal article or a critically appraised topic to present, and we put that presentation out on demand for people to kind of watch as well. And we're happy for everybody to get involved. So if you have any questions, you can pop them in the Q&A box, which is the little question mark box you can see to the bar on your left. But you can also send us any comments or queries or any suggestions to our email address, which is clinical@imv-imaging.com. So this month it's my turn to choose a paper. So I've chosen a journal article from the Journal of Small Animal Practice that was published just recently. It was actually on early access just now, so I've got that from there. So it's a paper looking at the endoscopic treatment of acute oropharyngeal stick injuries in dogs, and it's a retrospective study. So, a bit of an introduction to oropharyngeal stick injuries. I think we know why these occur and why these happen really as well, but you can categorize them as acute, whether they happen or presented in the first 7 days post the incident, or chronic if they happen greater than 7 days afterwards as well. And typically, these are kind of middle to large breed dogs that are presented, usually because they've been chasing, sort of fetching, or carrying a stick from there. This clinical signs we associate with the different time periods are kind of what we'd expect. So in the acute phase is usually presented with oral pain and bleeding. Usually there's been a noted incident where the stick injury has occurred, and dogs might be hypersalivating, have cervical swellings, and have other clinical signs associated with the damage to the oropharyngeal area as well. If they're chronic, sort of after 7 days since the incident happened, usually looking at cervical swelling and discharging sinuses, often associated with a foreign body as well. So generally, the prognosis for stick injuries, as quoted in sort of other papers, is quite good with relatively high survival rates, but less favourable, understandably, when injury occurs to the esophagus as well too. But the primary aim of treatment is getting rid of any foreign material that might be still in the injury site, and typically there's imaging involved in the initial assessment as well. So most commonly radiography, looking for the signs of emphysema or air accumulation in other areas like the pneumomediastinum or pneumothorax as well from there, but also the signs of the foreign material itself or associated effusions in the pleural or mediastinal spaces. And then similarly, along with radiography, MRI and CT can be useful for detecting foreign bodies in chronic cases. So I think it's something you've seen if there's a suspected more chronic foreign body, MRI and CT is very useful for finding where that might be. And typically the treatment is looking at surgically exploring the area of the injury, making sure any foreign body or foreign material is removed, and then debriding and sort of lavaging that area as well. So the aim of this study was to evaluate whether the management of acute oropharyngeal stick injuries with rigid endoscopy results in favourable long-term outcomes and a low recurrence rate in a larger cohort of dogs. So as I mentioned, this was a retrospective study at a UK referral centre, sort of looking at cases from January 2010 to December 2020. And this was focused on acute cases that had rigid endoscopy performed. So acute cases being those that presented less than 7 days after the initial injury as well. In terms of what they did with the patients had a general anaesthetic to undergo endoscopies. That was kind of a fairly standard induction protocol that we'll see. They were usually pre-medded with an opiate and combined with medetomidine, induced with propofol and maintained an isoflurane as well. Perioperative antibiotics are administered at the surgeon's discretion, but typically they're being given a clavulanate potentiated amoxicillin in combination sometimes with other drugs like metronidazole. And then initially there was a thorough examination performed of the oropharyngeal area with a laryngoscope and manual removal of any large pieces of stick as well. And then following that, the patients had a mouth gag placed, and then the actual injury site and tract was then examined using a 0 to 30-degree forward oblique 2.7 millimeter diameter, 18 centimeter long rigid endoscope with a corresponding French sheath, of 14.5 gauge French sheath as well. So we've got a picture of a rigid endoscope on the right of the screen just now. The 0 to 30 degrees refers to the tip of it, just the kind of viewing area. A 0-degree one is flat, whereas a 30-degree one is angled, allowing a slightly different range of view, but the structures that you're seeing are at a slight angle to the position of the scope as well too. So when the scoping was performed, they did it using gravity-fed saline irrigation through the infusion port on the scopes themselves. And using the scope, they could remove any foreign material via forceps fed through the sheath. And it also facilitated low pressure lavage to eliminate and flush out any other foreign material as well. If the patient had a suspected esophageal injury from the stick injury, those were investigated using a flexible endoscope as well. And then these were typically treated and managed using esophageal bypass, which is where a feeding tube is placed or a peg tube is placed to avoid the esophagus, or in some cases, in addition, by a ventral cervical surgery to explore the region as well too. Any soft palate injuries encountered were repaired with Vicryl. And in the cases where the injury tracks from the sticks were too long for the scope to get to the end of them, they were able to surgically explore those at the discretion of the surgeon as well. And then following these procedures, if the dogs had had the endoscopy or with other surgical exploration, they were usually discharged on broad spectrum antibiotics, again, typically clavulanic potentiated amoxicillin and a non-steroidal meloxicam or carprofen as well. And then if they did have feeding tubes placed, if there was necessity due to the injury or due to esophageal bypass, they were given either nil by mouth or liquid tube feeds or soft food, depending on the case as well. And in this study, they basically graded complications as minor if they were needed medical treatment, or major if they needed repeat endoscopy or further surgical intervention was needed. And they graded the outcomes as excellent if the dogs had complete resolution of signs with no recurrence, and poor if there was a progression to a chronic esophageal stick injury, i.e. those that formed a cervical abscess in a draining tract. So the results of this study, there was 86 dogs identified which had stick injuries. 66 of those made the kind of category for being acute, but there was 46 that made the study population because they were the ones that were managed using rigid endoscopy as part of it as well. Typically, these were younger dogs, not unexpectedly, given they're probably the ones that are playing with sticks or having sticks thrown for them. And generally, they were presented quite quickly after injury. So usually within about the median time was about a day, but some of them as quickly as 2 hours afterwards as well. And I think 10 of those 46 had already had the sticks removed by the owners or referring vets as well too. I've just put two tables of summaries from the paper there, just to show, firstly, the summary of the presenting signs. So a bit like those we mentioned at the start, the top tables showing those very commonly and expectedly. We've got oral and neck pain, bleeding, lethargy, cervical swelling from the damage, and then other signs associated with damage to that area becoming less likely after that. And typically, when they're looking at the sites of damage, you're looking at the sort of pharyngeal area being the most common, followed by the soft palate and sublingual, and then less commonly the tonsils, esophagus, and larynx is the site of the damage as well too. Last stick injury I saw had a sublingual one that went right under the tongue and down the neck. So they can be really nasty if you've ever seen any of these before. So, as we'd expect, a lot of the patients had pre-endoscopic imaging performed. So this was done in 38 out of 46 of the cases as well. So about 30 of them had radiographs, 21 had CT scans, and 11 had both radiographs and CT scans as well too. Of those, 25 out of the 38 had cervical emphysema visible on either X-ray or CT. So I've just summarised in brackets just there. There was sort of 12 of the X-rays, 7 of the CT cases, and 6 of those that had both as well. 21 out of 38 had pneumomediastinum. So again, 4 of the X-rays, 7 of the CT cases, and 4 of the ones that had both as well. It's interesting to note that these signs were not present in all of these cases. So there's a reasonable number of the patients which didn't have cervical emphysema or pneumomediastinum visible on the imaging, despite having the stick injuries as well. Of the 21 dogs that had a CT scan, they went on to remove foreign material using endoscopy in 9 of those cases. And it's interesting to note that of those 9, 6 of them had detectable foreign bodies on CT, but 3 did not have detectable foreign material on CT. In those cases, the fragments that were eventually removed were quite small, so less than 5 millimeters in length. And they did report in the study that in cases where they didn't have detectable foreign material, there was some mineral attenuation noted on the scan. But it's interesting just to see that even with the sort of CT scans, not every sort of CT case that had foreign material removed had the sort of that reported after the scan as well. And similarly, 13 of the dogs that had radiographs and then went on to have foreign material removed in using endoscopy, only one of those had foreign material detectable on the radiographs. So again, it's just showing that potentially we could have radiographs and even with a lack of visible foreign body, there's still one present there as well. And then the last point in this slide is just a shout out to ultrasound, just because it's often forgotten that ultrasound can be quite useful in the cervical area for looking for foreign materials as well. But there was one dog that actually had ultrasonography performed and that identified the stick fragment as well. So it's very valuable to use ultrasound in some of these areas to look for foreign material as well. Carrying on with the results, so with the injury tracks from the stick injuries, they were typically between 1 and 20 centimeters long in about sort of the majority of patients. So either within the limits of what could be reached with the rigid endoscope. There's only 2 out of the 46 dogs that had longer tracks that then would have necessitated further investigation or surgical exploration because of the length of them as well. And they managed to remove foreign material using endoscope in about 50% of the cases, so 23 out of the 46 dogs. 4 of the dogs went on to have surgical exploration along with endoscopy, and this was in cases where either the fragments of stick were very large, the tracks exceeded the length of the endoscope, or in those cases where they had esophageal damage as well. 5 of the dogs in the study had minor complications during hospitalization. These were generally mild sort of GI signs, typically related to the anesthetic protocols and the medications. And there was one that had a sort of neutropenia and raised liver enzymes that improved post-study as well. 3 dogs had major complications during hospitalization. This was one that had they suspected a pre-existing aspiration pneumonia. One developed a cervical abscess very quickly that had grass material found within it as well. And another one had wound dehiscence. And then there was one dog that had major complications post-discharge that had remaining foreign material that hadn't been removed and needed repeat sort of surgery and exploration for that. And they were able to do long-term follow-up for 40 out of the 46 cases, and the overall outcome was excellent, graded as excellent in 38 out of the 40 cases that they followed up. So moving on to the discussion of it, so the use of rigid endoscopy in these oropharyngeal stick injuries generally provided an excellent outcome with a low risk of patients proceeding to form cervical abscesses as well. They note on the paper that the case selection is important for because there's many injuries that are not suitable for endoscopy alone as well. So in many of the cases where if you've got very shallow injury sites where there's esophageal damage and more sort of surgical exploration is needed, long wound tracks that the endoscope can't reach or an extension into other areas, namely the thorax, there's going to be reasons why there'll be other things needed, such as surgery and further diagnostics. But even in a lot of these cases where they had these, endoscopy was still very useless for diagnosis and retrieving foreign bodies and lavaging the sites as well. So even the cases where endoscopy may not be able to be the only thing that's used to explore it, remove all the bits of stick and flush it out, it's still quite useful in those other cases because you can still provide a lot of benefits for foreign body retrievable as well. As we mentioned before, the esophageal injuries do require flexible endoscopy for assessment, so it's not like a rigid endoscopy provides any advantage for looking into the esophagus as well. And as we highlighted with the image, there's quite a possibility of false negatives with radiography alone. As we saw, there was lots of those cases that were radiographed that didn't have foreign material apparent, but then later went on to have it removed with the endoscopy. And similarly with CT, even in that more advanced modality, there was a number of cases where they couldn't detect the presence of a stick as well too. So it just sort of highlights that if we've got these imaging cases, there is that risk that even though we can't see foreign material, we can't really rule out that there isn't stick material there for certain. The main thing that's highlighted up with the paper is to remember that these are acute cases, and it certainly makes sense to manage them as soon as possible. When the sort of tracks are open, the injuries are fresh, it's easier to then explore them and find these areas before any sort of any kind of remodeling or changes occur. So just quoting from the paper itself, they sort of put this quote that the use of rigid endoscopy in the manage of acute oropharyngeal stick injuries is a safe technique that allows direct visualization of the tracts and can be the sole means by which acute stick injuries are treated for most patients. And therefore, they recommend the use of rigid endoscopy in the diagnostic and treatment plan for acute stick injuries as well. So it makes sense. It was definitely extremely useful for them to be able to use rigid endoscopy for that. Saying that, it's still recommended to perform initial survey radiographs of the cervical and thoracic regions to look at the extent of the damage and to get more information. So although a sort of rigid endoscopy can be the sole means, it's one of these things that in a lot of cases is still the recommendation to perform radiography or perform further imaging just to look at the extent of the damage as well too. And then certainly from this paper, the progression of dogs that were treated using endoscopy, and it was less likely that they progressed on to develop chronic injuries where cervical abscessation occurred. So in a lot of cases, the endoscopy seemed very successful at removing the foreign material and preventing any progression to abscessation. A couple of the limitations just of the study itself. So it's a retrospective small study. So with it being retrospective, there's a lot of variability in the approaches. So there's a lot of variability over the approaches to imaging, the decisions made around the endoscopy, and then especially with the reporting of follow-up information and complications, where they're relying on information from referral practices and surveys of the owners as well. So there's a lot of variability in how each thing was approached and then reported afterwards. Um, Certainly in this study, as we see with a lot of them are being performing with relatively expensive equipment. So there's a lot of cases where rigid endoscopy might not be available, and it does require technical expertise. The endoscopy was being performed by sort of referral surgeons as well. So these are people who are quite used to using the equipment as well. So it's hard to draw conclusions about how successful the treatment will be in a more of a general practice setting. But that doesn't mean the paper didn't highlight the kind of benefits of using rigid endoscopy for these types of injuries. And then they mentioned a bit of bias in the cases. So on one hand, you have bias with the fact that potentially the cases might have been generally more severe because they were ones that were being referred rather than managed. Also, interestingly, it's potential that the use of the rigid endoscopy may bias towards less severe cases because they are inherently the kind of cases where rigid endoscopy will be used to explore the tract. So, more severe injuries where the sort of wounding extends further or enters the thoracic cavity might have completely different approaches and not have had rigid endoscopy performed. So, looking at the sort of clinical relevance of it, or sort of summing up, it certainly seems from this paper that they've highlighted the use of rigid endoscopy and shown that it's safe and recommended for use in acute oropharyngeal stick injuries. Whether that's sort of as a sort of sole method of lavaging and retrieving, lavaging the wounds and retrieving the foreign bodies, or whether it's part of the kind of diagnosis as well to explore these sites, it definitely provides a lot of benefits and be able to directly visualize these injury tracks and remove this material as well. So it's certainly shown that there is a benefit to that. And I think that feeds into then if people are considering the use of this equipment or thinking about rigid endoscopy equipment for other reasons in the practice, that you've got this certainly this benefit for cases if where you have a stick injury case. This can be very useful as part of the investigation and treatment of those as well. I think certainly as well, the paper just reminds with the radiography and the CT findings, just to be careful of sort of false negatives. And again, with the some of the cases as well that had things like cervical emphysema, not all of them had foreign body removal as well. But it just shows that probably to be aware of that there is some uncertainty around what you're seeing, and completely ruling out the presence of some foreign material may be very difficult from radiography alone. And again, if endoscopy is available, you have that extra tool for diagnosis. If it's not, it's something that's worthwhile being aware of too. That's it. So that was my run through the paper, my summary. Hopefully, it's given you a good idea of just what it highlighted and maybe made you think about the use of rigid endoscopy a little bit more. As I said, my name's Sam. If hope you've enjoyed the Journal Club. If you do want to look at any of our past Journal Club episodes, please check out our kind of website, www.imv-imaging.com, because we've got all of them on there. So there's loads of great paper and great research. We'll be back for another episode next month, so please stay tuned to our social media as well. If you want to get in touch, our email address is on the screen, or you can pop a question in the Q&A box and it will reach us as well. So if you've got a query, got a suggestion, or something else you'd like to see us look at, please just fire them at us. But otherwise, goodbye and have a great day.